elbow, one on the tardy posterolateral rotatory instability due to cubitus varus. And this makes me think that maybe it's not such an easy lesion, and we have to be careful about it. And what could we learn from this paper? 24 patients, 25 limbs. One was bilateral. Posterolateral instability 20 to 30 years after the onset. And this is a major problem with the pediatric orthopedic surgeons. We treat these patients, and then we don't have such a long follow-up, so we don't really know what's happening with them. So out of these 25 limbs, 7 needed a reconstruction of the lateral collateral ligament and an osteotomy. 10 just a reconstruction of the ligament. 4 were treated by an osteotomy alone, and 1 needed a total elbow arthroplasty. Here's another paper coming out a little bit later from Arrigoni, exactly calling the attention for the same problem. I have to say that I have several cases because I also work on a reference center. I don't have so many posterolateral instability, I have to say, but I have this case that really called me the attention because this is 1 year post-supracondylar fracture, and you see a varus deformity, and you can see how it progressed to an instability and ended up with a subluxation of this elbow. So definitely, there are some patients that probably ended up together with some kind of soft tissue problems, and if you have a mechanical problem, that will help to these deformities to develop. So I'm not saying that every cubitus varus is going to end up by having an instability, but some of them can, so you should follow up them. If you're not going to treat them, you should at least follow up on them, and if you see that the major instability is coming on, you should treat them as fast as possible. So if you're going to treat these patients, how should we treat them? I'm sure you have some experience on this. So who would do a closing lateral wedge osteotomy? Nobody? Who would decide to do a closing wedge osteotomy with a distal medial translation? Okay. What about a dome osteotomy? And an opening medial wedge osteotomy using an external fixator and lengthening on the medial side. Well, there is, as you can see here, different possibilities. And let's look a little bit about this, because the closing lateral wedge osteotomy probably is the most popularized one. You have several papers calling on this. I'm not going to go over all of them. But it's easy to understand. When you take out this wedge and you do a resection, what you're going to end up with a translation of the anatomical axis, and you have a promination on a prominent lateral condyle. And this makes the patients very unhappy because they were treated because of a deformity, and they ended up with another deformity. So the problem is not solved. And you see there is a lot of papers that call for functional results. They are good. But of course, they were good before the operation, so there was no major change on that. But from one deformity, they ended up with another deformity. And you realize that some of them call it's not an easy operation, because if you do a complete osteotomy, you really end up with a very severe, unstable problem. So there are high complications rates, like a lateral condylar prominence, instability, difficulty in correcting the internal correction, and neurological complications. So although, like this paper from Ernesti Poli that calls for 43% of complications on the x-rays, of course the clinical results and the functional results were very good. So what about a closing lateral wedge osteotomy with a buttress? So you try to make a buttress here on the medial side. This was my first operation that I did to correct the cubitus varus, and I still remember a nightmare on operation. First, you ended up by doing a posterior approach. This is something that nowadays I cross on my approaches to the elbow, except if you want to have to do a supra and intercondylar fracture. But besides that, I never use a posterior approach because you are messing up with the triceps, and this is going to have bad functional results in most of the cases, and particularly with children. So this is not a very easy way of approaching the problem. So you have this paper from Skaggs. So in order to avoid the lateral prominence of the lateral condyle, now you have 2 wedges. So you're making the things even more difficult. So now you have to bring your angles, your measuring tape to make sure you do it in a correct way. So I don't think you should do it in a difficult way. A domal osteotomy makes sense because you keep the alignment. But again, this calls for a procedural approach, and I think the clinical results regarding the triceps in the literature are not very good. So I think that, you know, some of the people were calling this for the closing lateral wedge osteotomy with translation, where you can really correct the alignment of the humerus. The problem with this is that we are dealing with a very unstable osteotomy. So how to stabilize this? K-wires? No. Figure-8 wire with 2 screws, and this was what the French were talking about. A plate? Does anybody use a plate for this? And what about external fixation? So how would you fix this? Yeah? Okay, let me show you my technique about this. You know, this is a different case, but you know, this gives you an impact on about how you can use an external fixator. But on this particular case, it was a kid with osteogenesis imperfecta. They ended up by having this severe deformity when I used a tailor frame, and you can see that it was not very well correct in terms of the alignment of the humerus, but clinically, the kid does not look so bad at all. But this gives me a hint how to approach these problems. And again, with the same case, I think first of all, you have to really analyze the problem. Remember, this is a deformity on the 3 planes. It's not just a pure varus deformity. It has also a rotational deformity. And sometimes you also have an extension deformity. You'll see that some of these children have a very difficult time to reach a full flexion. So you analyze on the X-ray where you're going to do the osteotomy. What I do is to have these key wires that give me the angle that you want to resect, and you can see they are divergent because I really want to have them at the end of the operation parallel, so I make sure that I'm correcting the rotation. How do I analyze the rotation? Clinically. I don't use any specific X-ray or CT scan to analyze this, but I think clinically you can have a very good idea of what you should do. So you do afterwards the osteotomy, you do the resection, and you keep these 2 shunt screws that it should stay parallel in both planes, and I use a little K-wire just to fix the rotation and give the stabilization. This is an example of what you have, so very simple external fixator, and these 2 screws with the K-wire are enough to correct this. And here you have the correction on the frontal plane. Also, there was a need to correct a little bit of the extension deformity, so you can see here that it looks a little bit crooked, but actually has a full correction in terms of the elbow. Usually I keep this for 3 weeks, the K-wire, and I keep the external fixator between 4 to 5 weeks, and I can take this out in the clinic without any problem and without anesthesia. And here you have the clinical result, and you can see that clinically it looks very good in terms of mobility, and also on the X-ray, the AP, and lateral full correction. And here you have the comparison between before and after. So in summary, this is a rare situation, unfortunately, and this is something that going back to the lateral pins entrance, I have seen in my country in the last 2 years a high recurrence on this problem of the cubitus virus, because there is no doubt if you don't do the lateral entrant pins in a proper way, you're going to end up with some problems of instability. And I have seen more these patients coming to me with a cubitus virus because of it. Malpractice in terms of the treatment of a supracondylar fracture. So my message all the time is if you don't do it perfectly by putting the 2 or 3 pins laterally, I'd rather do it cross pin. At least you try to avoid this problem. Because I have seen going, you know, just to give you an idea, in my 25 years of practice in pediatric orthopedics, I operated maybe 8 patients until 4 years ago. And in the last 4 years, I did 12 patients with the cubitus virus. And this shows what was the importance of the introducing of the lateral pins for people that are not so used to do so. So I don't think this is a cosmetic deformity, so you really have to follow up on this. You cannot say to a patient that comes up to you and has a cubitus varus to say, no, this is a cosmetic deformity, go away, you stay with that. If you don't want to correct the deformity, nothing is going to happen. It may happen. It may happen in instability, so you have to follow up these patients until maturity. There is a risk of lateral instability in the adult age, and that's why you have to follow them. Treatment, in my opinion, should be by complete osteotomy with a lateral wedge resection, but the medial translation of the distal fragment, because otherwise you're going to end up with a lateral condylar prominent. And the best way of stabilizing this with an external fixator, unilateral, in a very easy way. I don't know if you have any questions for this. Clear. Yeah. I don't think you're never going to be able to answer to that question, honestly. But so my message is follow up on these kids. Watch them. Yeah, just watch them and make sure. Because to tell the truth, that child that come up to me at the age of 10 with a very unstable elbow, I don't have the pictures here of it. He had, and this is something I cannot understand. He has a huge deformity on this particular case. Let me go back to this. So you really have here a major instability in the elbow now, and this kid has 45 to 100 degrees of motion. So I just did a valgus osteotomy. And after the operation, he had 0 to 120. How to explain that? I can. Huh? I don't know. Honestly, I don't know how to explain how immediately he regained the range of motion. Of course, he's going to have still a little bit of a crooked elbow because it's very difficult now to stabilize this. And I'm looking forward to see how it's going to improve. Is this because you balanced the ligaments? You took out the tension?
The other issue I was going to say that we have where I work is there are 16 of us, and one of my colleagues, David Goodyear, had one of these when he was a kid, and he's about 45 degrees. And every time we have a discussion, he'll say,
Yeah.
Look at mine, nothing other way. That happened to me. And everyone goes, yeah, fair enough. So that's the problem. Is there are lots of people who have good function that no problem.
But that's exactly the way I was taught. So every time I would say, no, you don't have to do anything, just leave it alone. And nowadays, after this paper from Maury, from the Clinic of Mayo, and from these patients that I've been seeing now, I'm a little bit more concerned. So I explain to the parents, either if you want to correct this, you play on the safe side, because this is a very easy operation. I have no complication. I had one ulnar nerve transient paresia. Neuropraxia, yes, sorry, thank you. A neuropraxia transient that, and I know why I did, because when I was putting the chest screw, it went a little bit further, and then I had to come back, and 3 weeks later he was recovering without any problem at all. So I think if you are very careful, this is a very easy operation with no complications, I would say, if you play on the safe side. So I always explain to the parents what's going on. If you want to wait and see how it's going, because I know that the percentage, for sure, from the experience that I'm having, the percentage of children that are going to get a posterolateral instability in adult life will be very small. That's my feeling. Yes?
After the cubitus varus, breast trauma, cubitus varus after the removal of the plaster, after how many days you have to do the osteotomy?
How long do I wait to do an osteotomy? Yeah, I expect them to have full range of motion. So usually if I have because sometimes the parents are treated someplace else, the children are treated someplace else, and the parents, when they took out the plaster, look at it and they see it's not right. So they come for a second opinion. And I will always tell them, let's wait until he gains full range of motion, because actually, when he gets the extension, the deformity is going to even get worse. So it's more recognized. So it's up to them to decide if they want to do an osteotomy right away, or if they want to wait and see if there is any complication. I don't say that they have to be corrected. I talk to them and I explain that in the literature there is now this calling the attention for this problem, but you can be waiting, and if they don't want to be operated, I just follow them 1 year later, do an x-ray and see how they are growing. Because this is one of the problems with the children. Some fractures, I think you need to follow them until they get to skeletal maturity.
How much deformity, varus deformity, how much the deformity you will operate after?
How much?
How much is the deformity?
Varus angle, does it have to be?
Varus angle.
You do it.
In the indication, varus angle wise.
How bad is the cubitus varus?
Oh, okay. Yeah, I don't think there is a ruler for how much deformity you need to operate. Because as I said, probably the cubitus varus that ended up with some instability, it's because besides having the deformity, they will have also some soft tissue problem. And now when I'm dedicating a lot of attention to the elbow instability in the children and adolescents, I have been seeing some problems that you cannot diagnose in the first day. So some children, for example, we have a simple elbow instability, but you see there is it's very swollen. So because usually if you have an elbow dislocation, you relocate, and if there is no fractures around, sometimes you see a little bit of an avulsion here and there. And if you have an avulsion on the lateral side, now I'm paying too much more attention to this. So if I have an elbow dislocation, I take into general anesthesia, and I always test these patients. And if they have an avulsion on the lateral side, I try to fix it, the lateral collateral ligament. Because I know that these patients, if you don't fix them, they'll end up with some callus formation. There can be some impairment in terms of flexion. And I already treated 3 patients like this. So these are very small numbers, but that's something that you have to be alert to these problems. So I think it's important that whenever you have an elbow dislocation, that you test it and make sure there is no soft tissue problems. And I'm sure that, the supracondylar fractures also, you say, okay, if there is a fracture, why are you going to have an avulsion of the ligament at the same time? I don't know what will be exactly the mechanism, but I'm sure that some of the problems here, because on this guy, he had this problem 3 years after the fracture. So you talk about the paper from Mowry, and it's 20 to 30 years down the line. You say it's a micro wear of the ligaments with a long time. And I think we have to be alert, pediatric orthopedic surgeons, for a possible soft tissue lesion associated with this type of fracture.
But it's like ankle fractures, because it's a
Yeah.
rotational fracture, a larger hands.
Yeah, exactly.
Take different parts of the soft tissue as well, depending on the mechanism.
Yeah. Okay, so if there's no more questions, we go again up to the shoulder and coming to an easy one. Sorry, not this one. I apologize. So this here, 8-year-old girl fell from the height. Her parents were playing for our Philharmonic Orchestra in Lisbon, and she fell where the orchestra was, down, all the way down, and ended up with this fracture. You see pain and deformity of the left shoulder, no vascular neurological complications. This is the X-ray. Usually we only do on the shoulder one plane, no real lateral. So how would you treat this girl? She's 8 years old. Sling, just a sling? Velpo type? Sling. No close reduction with K-wire? No close reduction in intramedullary nailing. Nobody would operate on this, no? Okay. And what are you going to say to the parents? Should she come up in wait days time, or you ask her to come up in 3 weeks time? What? Okay. So she was treated with a sling, and then this is the picture after 1 week time. Now you have a completely displaced fracture, but well aligned on the AP. So how, it's 80 years old, would you accept this? No? Yes? Who says yes? Okay. Who says no? Okay, you guys are very shy. We really needed a voting system on this. Yeah, it's very difficult because actually this patient come up to me because when she was seen at a hospital, a general hospital around Lisbon, said, we need to operate on you. So they came again for a second opinion. And then I said, no, just to keep it on a sling and we'll do well without any trouble. Then they went to London, not to see Manoj, but your cousin. And actually in London they said the same thing, keep it going in this way. So this is actually because it has a very high remodeling potential on this lesion. And there are some articles published related to this, and one from IOACON here. And they come up with some guidelines in terms of, so if you have girls under 13 or boys under 15 years of age, they would accept up to this age. We are talking about a girl that is 8, but they will accept 50% of translation up to the age of 13 in a girl and 15 on a boy. And they will accept up to 20 degrees of angulation up to this age. This comes on tension 2. So another paper from Fernandez and Thomas with the patients up to 10 years of age, they would accept 60 degrees of varus intervention on retroversion up to the age of 10. So you can see that there is some papers in the literature that really call the attention that it has a high potential of remodeling. And here you have an example of this patient. This was after 3 weeks. And the good thing, if you understand that, is if you have the sleeve of the periosteum, you'll make the callus very easily. And the other part is coming out of the sleeve, you're going to be reabsorbed very fast. So on this particular patient, after 9 months, that's what you have, almost a complete remodeling on the AP and the both lateral view. So I don't think, in terms of a shortening, when you go like this, if this was a femur fracture in an 8-year-old, would you accept this? No? If you say it's a 5-year-old. Yes, probably yes. Okay, I put the 8 year because she's an 8-year-old a girl. And probably in an 8-year-old on a femur fracture, you would treat it in a different way. I would accept that. But if you see this a femur fracture on a 5-year-old, we are used to have all this full translation, and we are confident with it. So don't get panic when you look at humors and you feel something like this. So in summary, this is a common fracture. 3% of all pediatric fractures is an anatomic region with a very high growth. So it represents 80% of the growth of the arm. So there is a high potential for remodeling. So I think there is a little bit of a failure in defining the age, how much you should accept. But if you look at those papers from Iowa, comes up to 20 degrees up to the age of 15 for the boys, 13 for the girls. But you can see from the paper from Thomas Wirth, 60 degrees up to the age of 10. So keep that in your mind and don't rush to do a surgical intervention on this kind of patients and be as conservative as possible. Okay, open for the questions. No questions?
If you do intervene, what do you tend to do? Say it's very angulated or it doesn't improve the shape.
I tend to manipulate them and to put true crosswire pins. There are some people that are thinking about doing the S-ing, you know, the elastic nails. But for my problem, I think it works very well. I also have some patients that I did that. Because sometimes when it came out, the description of the technique, found it was very fancy to go in this direction, and it works. I'm very familiar with the elastic nails. But the problem is that you have to do a second operation to take out the nails, and with the K-wires, just pull them out. And it's such high potential of remodeling on this region that, for example, the other day we had a judo champion, 17 years of age, and he had still his growth plates very open, so he has a good margin of growth. And I remember he was referred to our shoulder surgeon, and then he called me, this guy is 17, still growth plates open, what do you think about it? Because he was ready to go in and to do a plate and screws, but then he said, maybe, you know, this is an adolescent, has some potential growth, what do you think? Because if you think about treating this conservatively, or not open, if you just do manipulation in the K-wires, you know better what you can accept or not accept. So I think it was very wise of him. And the truth is that we ended up with degrees of angulation, not a perfect anatomical reduction. But in 3 months, it was anatomical what it is. And for an athlete, I think it's much better than have a scar, the plates and the screws and so on. So I think it was the perfect decision on this. So to tell the truth, is still one of the places where I like to use the K-wires. I don't know if you do the same. Yeah?
I don't like reoperating.
Yeah. For no reasons, exactly. Yeah, I think we suggest to go for a little coffee break, so we'll see again in 15 minutes. Is that okay? So you have a little bit of relaxation. And deformity on the right wrist. This is the clinical deformity that you can see. No vascular or neurologic complications, and the X-ray is this one. So the first question I'm asking you, I told you it's a very common fracture. So what is the percentage? 12%, 22, 32, or 42? Of all fractures. All children fractures. 20? 42? It goes around the 32. So actually, if you look at this, you know, 1/3 of the fractures that you see are just located here. And it makes sense because all the children, first time they are falling out, they use their hands as bumpers, and that's what they get their fractures. So the second question, because you're going to see this very often, is how you're going to treat this. What will be your best treatment? Like this? No reduction? So who talks about plaster only? Just putting a plaster and that's it? Then you have a closed reduction and a local anesthesia plus a plaster. Local anesthesia? Okay, short. So you have here a closed reduction, and you can discuss this if you're going to put a K-wire or not on this, and a plaster, and a closed reduction with an elastic nail. This nobody will do it. Okay, let's see a little bit of the discussion on this. Oops. The first thing that I want to call your attention is that when you look at about the distal third, usually I consider on this little segment of the forearm, you can have 3 different patterns of injury. One is on the growth plate. So when you see it like this, one is on the growth plate. The second one is the metaphysis, and the third one is the distal third. And there is a tendency sometimes to look at the metaphysis and the distal third in the same way. And I think it should be looked in a different way because the approach in terms of treatment and the complications will be also a little bit different on this. How do you find out where the metaphysis is? It's very easy because you use the Yale rule where you take a square. So you know what is the square in terms of the distance of the both bones, the radio and the ulna, and you take the same distance, the width, and you take the same distance with the length, and you ended up with a square. So that's where you get the metaphysis. So going back a little bit, what happened in the shoulder, also here, you have a very high potential remodeling. And this is why everybody will say, okay, close reduction, but plaster. Because you never think about operating on this type of fractures, probably. So there are several papers in the literature. This is one of that it was complete remodeling, even in the presence of angulations in more than 15 degrees. I presented at an effort meeting, but a long time ago, our own experience from our institution on 28 cases with angulations up to 28 degrees. Because again, they will come to reference center and say, this is angulated, what are you going to do? And you just left them alone and to heal by themselves. The age was between 5 and 12 with a follow-up at 2 years' time. They all had full range of motion, and the X-ray with full remodeling, 86%. So probably with the growth, they will remodel even better. Here you have a good example. At the 5 weeks time, we have this kind of angulation of 20 degrees on the AP and 28 on the lateral. And you can see that in 2.5 years time, you can see the full remodeling of the deformity. However, I call the attention, because I don't know in the long term if this will have any problem or not, but when you compare the AP, you can see that there is a different angulation of the growth plate on the radio on both of them. So we know that some of the correction gets up on the growth plate, and some of it corrects at the deformity itself. The truth is that in our patients, we did not find any problem in terms of the range of motion, and none of the children were complaining of pain, but I don't know at the skeletal maturity if this will have any influence or not. You have another paper here from Planka that with a complete remodeling of the radius nearer to his anatomical position, again with 86%, so very similar to our results. The better results, of course, it was the younger patients between 0 to 12 years. And the funny thing is that, and I have will be able to correlate that in our series, but in this particular series there was less residual dislocation within 20 millimeters from the growth plate. So this patient from Freiberg also called for a normalization even with a primary angulation more than 20 degrees. And this is more or less what we try to get to the upper limit. Again, it's very difficult to correlate this with age. I don't think there is too much rules in terms of saying what age you should accept or not, but I'll try to come back to this a little bit later on. What I also would like you to have in mind is that what is important of getting an angulation in the first time. If you're going to accept a kind of angulation, non-anatomical reduction, you have to be aware that this patient should be kept under surveillance in the first 2 to 3 weeks. So it's not something that... So sometimes I really have a difficult time to decide when we have to fix it or not. There was a paper, I cannot remember who published that, and I apologize for it, because the question is, when you do the reduction under a general anesthesia, you make, in a certain way, have a feeling if it is stable or unstable. So it feels like you do a reduction, and then you try to dislocate the fracture again. And this can give you some idea how stable or unstable these fractures are. Because at least, for example, and I'll talk to you about on this, when we have a very unstable fracture, and it's very difficult to reduce, because if it's totally dislocated, this fracture, sometimes it's not so easy to reduce. So what we do is to use a K-wire through the fracture itself, and try to use at the lever arm, you just place it distally, and then you ended up by having an anatomical reduction. And what you just do afterwards is to put the K-wire through the distal cortex. So we keep it like this for 3 weeks' time, and it helps you to stabilize and giving during that period of the first 3 weeks. Because what is the danger of having a K-wire here? What do you feel afraid of having a K-wire on the wrist with a K-wire sticking out? Infection. So if you keep it for 3 weeks, the probability of having an infection, we have been treating a lot of these patients with this technique, and we never had any infection at all. So by 3 weeks, you take out the plaster and substitute the splint for a full plaster just on the forearm, and it works perfectly. So I think this is one of the examples of what we're talking about. A completely displaced fracture of the distal metaphyseal. Just put the key wire for reduction and then fixation, and you can see a perfect reduction at 3 weeks' time with a very good clinical result, very good clinical result. So any questions about the distal metaphysis? Okay, so keep in mind this possibility of using the Kappanji. Then let's go now to the distal third, because this is not a metaphyseal fracture, but this diaphyseal fracture. And this can be very unstable, because sometimes you have what we call a Galeazzi fracture dislocation, where you can see that the ulna sometimes is popping out on the dorsal side, as you can see here, and there you really have a very unstable fracture. So it's difficult the fixation, because if you think about putting the K wires through this type of fracture, you really have to be an expert. It's not so easy. So how should we handle that? Usually, I think if you keep in mind to use the same principle as for the metaphyseal fractures, so conservative treatment, non-operative, probably is the best way of approaching this, unless you are having an unstable fracture, because this means that surgical indications on this type of fracture will be rare, however. But when you ended up with something like this, that you have some very unstable here fracture, how would you treat it? Close reduction and a plaster? Kappanji, like I show you for the metaphyseal? No. Cross key wires? And what about elastic nails? Yes? Any other idea? Yeah, you know, sometimes you can treat these patients, you're correct, as an adult, and especially if it's like a 15 or a 16-year-old, I think you can use a plate on the anterior side and treat this properly. So what is the acceptable residual angulation? I think this is the basic table that you should have on your mind in terms of dealing with the distal fractures of the radius. And you can see there is a difference between age 4 and 9, 9 to 11, 11 to 13, and more than 13. And also a difference between boys and girls, and we're looking at a frontal plane. And you can see that we are very conservative in terms of coming out with these measurements, because, for example, my own experience, you could see that it was accepting up to 28 degrees in our own experience, and all did well. But if you keep it on play on the safe side, I think it's better that you can stick to this table published by Rockwood and Green. So how to approach if you really have this totally displaced fracture, as you can see here? We discussed about the Essing. You know what is the gold standard, what is the technique, what are we trying to achieve? Because when you use the elastic nails on a tibia or on the femur, for example, we try to use a 3-point fixation and try to make it as most separated the nails at the level of the fracture. But here, we don't have 2 nails. So what we try to use is a convex nail that will stay with a concavity looking at the inside of the forearm. That means that you try to separate both the radius and the ulna. The problem, as you can see here in the radius, because the lateral, the entrance on the radial side, usually it's very lateral on the radial side. So what happens is that you have, if you have a fracture very low, you have the nail make an impingement on the fracture site. So what has been our experience by using the elastic nails on this type of fracture, on the distal radius, is that you ended up by having a deformity a little bit with an ulnar deformity of the radius. So the radius, the articular surface, is looking at the ulna. So we were not very happy with this, and we try to divide a new technique by going on the ulnar side of the radius, because this way you can really have a stable concave stress that will make you the reduction look a little bit better, like you can see here on this side. And how do you do that? This is something that requires, because most of the elastic nails, we try to do it with a blind technique. We make a little incision because we know that we are on the safe side, and put the nails without caring too much about the soft tissue. If you are putting a nail on the ulnar side, you have to open and see what you are doing, because your point of entry will be between the extensor of the fifth and the extensor of the fingers. So you have to make sure that you are not cutting any of the tendons that are responsible for the extension of your fingers. So it cannot be a blind incision. You have to really look inside and make sure that you are putting this nail on the correct position. But if you are doing so, then you're going to be able to really give this aspect, as you can see here. That's exactly what you want to have, to put the membrane, the interosseous membrane, under tension and have a correct and anatomical reduction. So when you look at the distal third, definitely is the most common fracture in children. 32.9% of all pediatric fractures. However, this is a region like the shoulder where you have a very high potential of remodeling. So most of these fractures should be treated non-operatively. Any questions? Clear cut. So I'll continue with my talks, and then Ashok will come out with your two talks. So you're going down a little bit. Also, not such a common fracture, but this is a region where you can get into a lot of trouble. So this is a 13-year-old male that fell playing soccer. He came to the clinic referring pain to the right knee, mostly. Of course, the GP that was seeing these patients decided, besides having the knee x-rays, he also took an x-ray on the hip, and he thought that both were normal, and was medicated with a non-steroid anti-inflammatory drugs. Do you see anything here special in particular that you feel worried about? Yeah. And, you know, this is something that when I look at our femoral neck fractures in our institution, I realize that 12% of them had a misdiagnosis. So I think that most of the people that are the primary care are not alert for femoral neck fractures in children or adolescents, and they miss this out. And this is also published in the literature. So I think we have to be a little bit careful about this. I don't know how much of you are familiar with the Dalbert classification that we have here. I think it's important that you get familiar with it, because it has some indications in terms of treatment, and definitely has indications in terms of prognosis. So you really have to look when you see those patients and see how you're going to talk to the parents and say what is the outcome always expected from this type of fracture. So you have here the type 1, that is a transphysial fracture. The type 2 is a transcervical, over the cervical neck. The type 3 is a cervical trochanteric, so it's the base at the femoral neck. And the type 4 is an intertrochanteric. And you can imagine when you move from type 1 to type 4 that the complications rate will go lower. Why? Because of the vascular supply. So when you treat these patients, we have been talking about Pertis and Skiffis, so we have been discussing a lot about vascularization on the femoral neck. This is a very particular region, and this is our major problem, a vascular necrosis. The second major problem, what is it? Because this is the same x-ray of the patient that was walking with crutches, and he came back because he was not feeling better 3 weeks after the initial treatment. What do you have now here? A varus deformity. So another problem that you ended up here on this region is malunion or non-union. So you have a vascular necrosis, and then you have the problems of the local complications like a malunion or non-union. So this is all the above. That was your next question. A little bit of discussion on this. I think it's important to know because there was a major change in the last years. What did it really change in the last years that also may change the prognosis? Is that when you compare the early results with the late results that we have now, we change the hardware. So we are much better at stabilizing this fracture that we used 20 years ago. 20 years ago, we stabilized these fractures either with a plaster or some K-wire, so very unstable way of fixation. Now we have special devices that allow a better fixation, and this really improved the diagnosis. And this is more or less what you can see. Of course, when you go back to the early papers from 1990 or 1999, what you can see is that, for example, in this article by Canale, when you compare his results of 25 patients after 1970 treated aggressively with historic series that they had on their own institution, they documented a significant improvement on the overall vascular necrosis rate from 43 to 24%. So this was a major improvement. So what are the additional risks for AVN? Fracture displacement? Time to decompression? Do you think this is an important thing? Type of fixation? All the above. Yes. Keep this in your mind if you are dealing with a femoral neck fracture. You really have to look at the fracture displacement. So if you have a displaced fracture, it's really an emergency to treat this patient. You really need to fix as fast as possible. You need to decompress, although we'll discuss this a little bit later on, but I think you should do it. And also the type of fixation. You should look for the best and more stable fixation possible, because this is what it was shown in the literature that is the major point in terms of avoiding AVN. What is the role of decompression? We already heard about this on the SCIFIS, and here, although there is not really very much evidence, because you have contradictory papers with different actors, from one supporting and the other one say there's not making any difference if you do compress it or not. In my own experience, I feel much more comfortable if I decompress, because you have an hematoma inside of a capsule that sometimes is locked and you have a high pressure inside. So you never know what's going to happen with the synovial vessels that are compressed by this hematoma. So I rather do this. Usually I do a T approach, and you can see on this T on the base of the femoral neck, just above the circumflex artery, and I think we are on the safe side to avoid any further damage. So what is make the experience from the Mayo Clinic again? So they publish a lot, not only on the elbow, but also for fractures of the femoral neck. And when you look at their 30-year experience, stability and quality of the reduction were the major factors improving the outcome on this type of fractures. And AVN was associated with inadequate reduction and use of older implant sites. The other thing that we discussed, it was a non-union that occurs around 10% of the patients, several publications on this, and again, I think it was mostly related to the hardware that the people were using at those days. Again, this paper from Chang calling for a lot of complications, again related in the same way to the use of different hardware. So, going back to our patient, you remember that we have now a 3 weeks time. We have already a varus deformity here. You have some callus formation. How would you approach this patient? 3 weeks after the initial accident? So at this moment, the patient was getting better. He was able to move his hip, a little bit in pain, but not so bad. So shall we keep him observing and expect that this fracture will remodel? No. No reduction, just osteosynthesis, so very good hardware to stabilize this fracture. Is enough? How do you feel about that? Open reduction. You talk about anatomical reduction. It's one of the best things. You think that it makes sense to do an open reduction at 3 weeks' time? Maybe this will be here for the panel. Ashok and Manoj, what do you guys think about doing that? Yeah. Open reduction at 3 weeks' time, exactly. Already with some callus on there. Yeah? And you, Ashok?
Just try a reduction. Give traction. Dose reduction and affection. Because in walking on it, it may not have actually done that.
Yeah, he was walking on crutches, so he was, and that's why he moved into a varus deformity. You're right. I have to say that when I got this patient at 3 weeks' time, I was a little bit concerned. So I rang my good friend Pierre Lascombe and discussed this over the phone. What shall we do? And we discussed different possibilities, because the first thing, we know that we need anatomical reduction. So it will make all the sense to go in and do an anatomical reduction. But then we thought about, well, it's already 3 weeks' time. You have already some healing process. If I'm going to do an open reduction, I have to destroy all of this and keep it going back. What's going to happen with the vascular supply? So if this head is already dead and we do the scintigram at this time and there was a good vascular supply of the femoral head, so it will be a lot of pressure on my side. So I decided to do a different approach on this, maybe a little bit crazy. So this is what we decided to do, stabilize the femoral neck on this position and do, yes, a valgus and extension osteotomy. So the idea was to take out a wedge in an intertrochanteric region and stabilize it, so that's what we did. Unfortunately, that's one thing, not unfortunately because it went well without any problem, but nowadays I think if you are dealing with a patient that is less than 10 years of age, or above 10 years of age, you should not be afraid of crossing the growth plate to get a better stabilization. I think it's something that you have in your mind, because usually try to avoid to stay out of the growth plate. If you are dealing with a femoral neck fracture, stabilization is the key factor. So if you have a very small amount on your femoral neck, don't be afraid of crossing the growth plate to get that better stabilization, because it will be easier to then to shorten a little bit or to do an epiphysiodesia on the contralateral side. But what you want to make sure this heals in a proper way. So this is what we did for this patient, and it was working properly. You can see here that we did not touch on the lateral view. It's a very high deformity that we decided it was not so easy to put the screws in to be in a proper place, but what you're going to see is very good remodeling of it. And 18 months on the post-op, this patient is doing well, playing soccer, doing his surf without any trouble. And I think it was a wise decision, maybe a little bit controversial, but this is to tell you also that every case has to be looked individually in a very specific way. So we can have general ideas how to approach these patients, but you also have to think individually. Could I apply, or should I get out a little bit out of the rules in a proper way? So here you have an example of how it happened. And what really impressed me was the ability to remodel the femoral neck on the lateral view.
We did a valgus osteotomy.
Valgus and a little bit of extension, flexion.
So what if you hadn't done any osteotomy, just for the protect?
I think I will ended up with a varus deformity, and I was afraid. I was afraid actually of getting a non-union. I had, again, you go back to your own experience. I have 3 cases in all of my series of femoral neck fractures. I have around 20 during all my life, operating, not so many. But I have 2 non-unions. They come up to me because they have a vertical. And nowadays, if I have a child with a very vertical line fracture, I always tend to include an intertrochanteric valgus osteotomy from the beginning, because it's a simple procedure, and it really helps you in terms of the stabilization and giving a more compressive forces around the fracture line. So actually, you're right. I thought about just keeping this the way it is. is trying to heal, exactly. So the kid was going around without any problem. So he was healing naturally. But I was afraid that he will get a non-union at this point, because this is the risk. You don't know if it's going to unite or getting into a non-union. So, in summary, rare fracture it is, but probably the worst place to have a fracture in a child is the femoral neck. You have to treat them properly to avoid complications, because they have a very high incidence of complications. They represent 1% of all pediatric fractures. You need to know the anatomy and the vascularization. You need to know the classification, because this correlates with the outcome. You know that it goes worse from 1 to 4, or it gets better from 1 to 4, sorry. There's a risk of complications. Just to give you an idea, if you have a type 1, you ended up by having almost 40% of the patients with complications. Now, type 2, 28%, type 3, 18%, and type 4, 5%. But you still ended up by having some cases of AVN in an intertrochanteric fracture. What we know from the literature for sure is that the better results are related to an anatomical reduction and a stable fixation. So when you go in and treat these patients, you have to make sure that you're going to have a very stable fixation. The role of decompression is not proven, so it's very difficult on the literature to say yes or no, but I think if you want to play on the safe side, it doesn't cost you too much. You are right there, so do a decompression of the capsule. Questions?
My only other question was that decompressive T-cut. Why do you put the horizontal limb distal?
Yeah, because it's true. We are used when we open the hip on for dislocation, DDH or something like that. You do the T on the upper part, proximal. But here, sometimes you are closer to the distal part, so you don't have to go so up to open that T. So I make a little incision, not a big T like it's there, but just a little incision, because you are closer, that's all. No other questions? So this is one of the cases from Bjarne Madsen, and I think this is a patient that you see more often. She's a 7-year-old with a diaphyseal femur fracture, as you can see here. It represents 1.4 to 1.7 of all pediatric fractures. You have to be careful if the child is less than 3 years of age of child abuse. I don't know how big the problem is here in India. Not so much? Okay, but for us in Europe, this is a major thing. So every time we get a child that is less than 3 years, we always do a workout. And if we are in doubt, we always put these patients in to make sure, discuss, and see how the family behaves and how can we manage if there's something behind this history or not. So, what is the approach here in India for a 7-year-old? Ender's nail? Okay, elastic nails. Yeah, that's your standard approach. Okay, let's go a little bit lower. If this child will be 5, how would you manage? The same way? Close in a spiker? And you do that immediately, or you put that in traction for a while and then do the spiker later? One at a time. Sorry?
1 week time can be given to reduce the
Okay. Because this is the old literature, and that's the evidence that we have. Traction plus plaster works very well, and everybody accepts it. The problem is how long you have to put these patients in traction in the hospital for a long time. And nowadays, especially in Europe, it's very difficult to keep them around. So I think we changed our way of treating these patients in the last 15 years, 20 years. And now I think that most of the people accept either, if it is a young child, I do an immediate spica cast and keep the patient in observation for some hours and send it home. And if it's more than 5, of course, depending also a little bit on the weight, then because sometimes it's not so easy to put a patient on a 90 degrees plaster. That's how you, what do you use, Manash?
Spica can be given same day.
Yeah.
There will be no harm.
Yeah, we send our patients home the same day, exactly.
Yes, yes.
Again, if you treat it non-operatively, the only problem is you have to follow up on these patients and make sure that you do not end up with a shortening of 4 centimeters the week after. That's the only thing you have to be.
Can be reduced very well under CR.
Yeah.
This can be reduced under CR, then the spica will be applied.
But sometimes if you try to reduce this under general anesthesia and fix it on the C-arm, see what's going on. Sometimes you don't have totally reduced. Sometimes it's not so easy. And sometimes it can displace and can displace again. So I think you need to keep watching these patients if you are treated them just with a plaster. So the answer to this, acceptable? No. So what are the, here you have an example what was done. These elastic nails. Does anybody want to comment on the techniques? Because it looks like a little bit on varus, a little bit of flexion.